patients. As we begin each program, we remind you that we do record these programs. The recording is for our colleagues and associates that can't be with us this evening, and so they can listen and watch at a later time. We never publish these or use these for any commercial purposes. If you don't want to be part of a recorded session, you're invited to leave the call now, and you're staying with us as your implied awareness of the recording. The program this evening provides 1 hour Category 1 AMA Physician CME credit and 1 hour of Virginia Nurses Association Continuing Education credit. Sovah Health is accredited by Southern States CME Collaborative to provide Category 1 CME. We're getting some echo somewhere. And we're accredited through the Virginia Nurses Association for nursing CEs. The program this evening was developed to promote 2 desirable physician attributes. That is, our providing patient-centered care and employing evidence-based medicine in our care. Dr. Reimer, our speaker this evening, has reported the following of these listed relationships, commercial relationships with what CME defines as an ineligible company. That is a company that provides patient services or products. As you can see on the slide, she's received research grants from Abbott, Chessie, Novo Nordisk, and Viartis, and served for a consultant for 3 of those. In order to mitigate those relationships, she has graciously agreed that we could review her slides, which we have. They contain no commercial bias, and that she'll be only presenting to you any treatment recommendations that are evidence-based and free of commercial bias. It's all peer-reviewed, and in this case, it comes from a very well-done, consensus-generated set of guidelines from American Heart. Myself and members of the Sovah Health CME Committee have no relationships to report to you. There is no commercial support for the program this evening. It, as is the case for all of our Sovah Health CME programs, is supported by the Ralph Landis Medical Education Fund that resides at the Danville Community College Educational Foundation. Dr. Landis, who founded Southside Urology, previously known as the Danville Urologic Clinic, very generously a number of years ago, donated a significant amount of money that has been held in trust by the hospital and then DCC Educational Foundation to serve as a support vehicle for honorarium for speakers, providing accredited continuing education for medical healthcare professionals. You will this evening receive a program evaluation by email from Mary. When you get that, you'll be asked to confirm the program date, etc., and you'll be asked to re-enter your name and your email. Please give us your full name, no short names or nicknames. The name you put on that eval form will be the name that will be on any CME certificates that are generated from that. Besides it being emailed, you also can click on a QR code that Mary will put in the chat box towards the end of the program, and it'll take you to the same evaluation form. The evaluations are not required of physicians to receive CME credit. However, for nurses, nurse practitioners, your accreditation process does require you to complete a CME evaluation form. There is a reflex email of CME certificates once those eval forms are received in the system. We like to remind the medical residents they do not have to keep up with those certificates. Your CME coordinators are informed of your participation, and they will track it as is required by your program. I always like to take just a moment to thank Mary Kent for making these programs possible. She manages the documents and the technical aspects of this, as well as Vandora Holt, who is the market director of education, particularly for nurses at Sovah Health, and she paralleling doing this allows us to provide the CME credit for nurses, nurse practitioners. So many thanks to them. If you have any questions about your evaluation and or certificates, please feel free to email any of the 3 of us or call us. We're more than happy to help you, and we want you to be sure and get the credits you've earned. I know Dr. Reimer will encourage questions and comments, and if you have one, you can put it in the chat. Even just speak up. When you do speak up, once you've made your comment or ask your question, if you would please mute your phone, it prevents feedback. You're urged and more than welcome to present as many comments and questions as you would like. Well, in fact, that really adds to the richness and effectiveness of the program. I want to mention a few upcoming programs that will be happening beginning next week. Next Thursday evening, we will have Dr. Aaron Getler, a member of the infectious disease division at Duke, also a member of the DASON network, talking about UTI stewardship. This, in some ways, is a brand new, if you will, take or optic on trying to use antibiotics appropriately and treat, in this case, urine infections when they are truly present, as opposed to chasing some, if you will, screening lab materials. And what's the best way to do that? And then paralleling that, the most evidence-based way and the best evidence-based way to treat the infection, including duration, and if you will, some tips on good management. A week after that, we've had one a week in February. Dr. Kimberly Beavers, the gastroenterologist here at Sovah Health, will be talking about colon cancer, its risk, its epidemiology, and the approved current screening mechanisms or tests that are being used and who should get what when. Finally, we'll have our last in the Cardiology 225 series on March 6th. In CME, you rarely get a, if you will, an encore presentation, but Dr. Green was identifying the needs assessment to be asked to come back and once again review the current guidelines for advanced heart failure management, and that'll be complemented by Dr. Fadim, another cardiologist at Duke, who'll be talking about a really unique approach that he has been leading the management program in doing, and that's remote monitoring of heart failure patients, installing a device in the patient that allows, if you will, a volume measurements, telemetry, so to speak, and it can be a way to truly help prevent readmissions to hospital and make patients much more functional. So this is frozen, but that's fine. Well, that being said, I'm sorry, but for some reason my Teams is frozen. The last slide was one just to again show you Dr. Reimer's picture. She's actually live on the camera if you want to see her there in a little thumbnail shot. We're delighted to have her. She's another one of the really great Duke interventional cardiologists. Her training began at Vanderbilt, where she received her MD degree, the same place my son received his. And that followed with internal medicine residencies at Duke, and then that followed by general cardiology or cardiovascular medicine fellowships and interventional cardiology fellowship, again being at Duke. She has had the recognition that she is a nationally recognized expert on, if you will, perioperative management. She participated in these New American Heart Association guidelines on cardiovascular management in the perioperative patient. So, Dr. Reimer, if you want to bring your slides up, I will try to take mine down. I think you're bringing them up will knock me off, which is just fine. Thanks so much.
Can you guys see everything now? I'm going to take this closed caption off the bottom.
Yes, ma'am. Looks great. Looks great. Thank you.
Wonderful. All right. Thank you, guys. I'm excited to be here with you all tonight to talk about, I think, a really important topic, which is perioperative management prior to non-cardiac surgery. And I think this is a really important topic. So I'm an interventional cardiologist, but I can tell you, even today, rounding in our ICU, I was dealing with issues that sort of resulted from maybe not stress testing a patient prior to a non-cardiac surgery, and sort of maybe some of the outcomes from those decisions. I think this is a really important topic to talk about. Please feel free at any point during this talk to stop me if you have questions, raise your hands. I will try to do my best to monitor sort of the sidebar here. Quickly, those are my disclosures already brought up here. So major changes, and I'm going to do my very best to go through these and make sure that that you guys understand what the major changes have been. There's really a systematic approach to a perioperative risk assessment, and we'll talk about what that exactly means and how I do it in clinic. Highly selective use of stress testing. I think in the past, if a patient was going through a relatively major surgery, you would always stress test. And I think now there's good strategies to figure out exactly which patients you should be and should not be. The SGLT2 inhibitors are widely being used now, and there's a big focus on making sure those are discontinued 3 to 4 days prior to surgery, and I'll talk about reasons why, around stopping oral anticoagulation and when to resume. And then a lot around this post-operative surveillance for patients that have an acute coronary syndrome or myocardial injury, and how to manage those patients. Also, patients with newly diagnosed atrial fibrillation and ensuring close follow-up during that period of time, and then what types of intraoperative cardiac imaging should be done. So here's a few, just a quick overview and look at the urgency of surgeries. I think this is really important to understand if it's emergent, if it's urgent, if it's time sensitive or elective, because particularly in some of the concepts I'll be talking about here in the next few minutes or in the next hour, if it's elective, a lot of things change in terms of the dual antiplatelet therapy versus if it's urgent or emergent, there may be other strategies we have to use. Now, if it's a low risk type of surgery, that's an endocrine, breast, gynecologic, or obstetric surgery. If it's intermediate or high risk, it's generally your orthopedic, your knee and hip replacements, genitourinary ENT. For high risk, that's vascular, thoracic, transplant, or neurosurgical. And then what does that overall mean? If it's low risk, that's a major adverse cardiovascular event rate of less than 1% if it's low risk. If it's an elevated risk, that's 1% or more in terms of MACE. And I think that that's really important. So you may say, well, how do I determine that? And I'm going to show you in the next couple of slides. But in general, if it's less than a 1% chance that the patient will have a major adverse cardiovascular event perioperatively, that's considered a low risk procedure. Now, predicting risk, and there's really great risk calculators out there. The Goldman Index has been around for a long time. The RCRI, I think, is more commonly used now. I think at Duke, we have that plugged into our electronic health record. There's the NSQIP surgical risk calculator. There's several others mentioned here. You may have different ones, certainly in your outpatient or inpatient setting, wherever you're focused. But if possible, I think try to have some risk calculator that you can use to evaluate the patient's risk. I typically use RCRI. And then for RCRI, there's this is widely available on MD Calc, so you can bring this up on your phone, you can bring this up on the intranet, and you can go through and really go through the questions and understand the patient's risk very, very quickly, which is nice. So if it's a high-risk surgery, the patient gets +1. If they have a history of ischemic heart disease, whether that be a history of a heart attack or current chest pain, if they're on nitrate therapy, you would give them 1. If they have a history of congestive heart failure, as you can see here, like if they have fluid in their lungs, if they have rolls on exam, if they have a chest x-ray showing pulmonary edema or other findings like that are suggestive of congestive heart failure, you would give them 1. They have a history of stroke or a TIA, 1. If they're already on insulin going into the surgery, 1. And then if they have a preoperative creatinine of greater than 2, you would give them 1. And so you may say, well, what is considered low risk surgery according to the RCRI? And that's typically if you get 1 point or less, that's low risk scoring. You can see here 0 points. Even if you're 0 points, that's a 3.9% risk of a major cardiovascular event. 1 point is still considered low risk, and then if you get to 2 or more, your risk is more intermediate. So I think this one's a great one. It's easy to use, easy to answer the questions. You can quickly find the answer to most of these questions in the patient's electronic health record, which is nice. But the other thing that I always consider is functional capacity and frailty. And I think we really underestimate, for instance, the importance of frailty in particular on how the patient is going to do postoperatively. So when you think about functional capacity, my sort of lay way of doing this in the office is to say, well, do you walk up 2 flights of stairs? Can you walk up 2 flights of stairs? And I oftentimes preface that by saying, can you walk up 2 flights of stairs without stopping? Can you keep going, or do you have to stop because you're really winded? And if the patient can, and oftentimes it's easy if they live in an apartment complex and they live on the 3rd floor, they're having to do that every day. So that indicates that they're at least able to do 4 METs or more of activity. There's also the Duke Activity Status Index, which is nice. I don't use that quite so frequently, but it is in the guidelines as a way to assess the functional capacity. That is also on MD Calc. So these are all things you can look up on your phone quickly and bring up these scoring indices. A recommendation to have some sort of structured assessment of functional capacity to risk stratify your patient. Now, for frailty, preoperative frailty assessment using some sort of validated tool can be useful for evaluating perioperative risk and guiding management. We know, for instance, that there's several validated instruments that I've listed here: the physical frailty phenotype, the frail scale, the clinical frailty scale. We know that women, frailty is 2 times higher in women than in men. And then we know that the prevalence is a little over 10% in patients who are 65 years and older. So important to get a sort of an understanding of what the patient's frailty is going into to the surgery. Now, this is the Duke Activity Index that I was talking about, and it gives certain weights to certain activities. And these are things like, can you walk around indoors, such as around your house? Can you walk a block or 2 on level ground? Could you run a short distance? Could you do light work around the house? And so a lot of these questions you may say, well, I just sort of asked that in regular history and physical. And I think that's important to know. You know, if you look at some of these that have higher weights, such as can you participate in strenuous sports or moderate recreational activities? If they're doing that, like I saw a patient the other day that plays pickleball a couple times a week in a league, that person has, you know, really high activity index score. They're able to do moderate recreational activities several times a week. So that patient would be at a lower risk for a perioperative bad outcome based on their functional capacity. Now, I see this quite frequently in my clinic. I have a clinic at Duke where I see a lot of patients coming in that are undergoing some sort of non-cardiac surgery, and they come in with an electrocardiogram. I had one just this past week. It had 1st-degree heart block, and the patient was quite worried, and they said, you know, I'm really worried that something's wrong with me. I have this heart block. But I think it's nice to have a basic list of what are the findings on electrocardiogram that would be really concerning. What are the ones that you should say, if a preoperative ECG shows this, that I might need to get some additional evaluation to further refine their cardiovascular risk. So those abnormalities really include some sort of ST elevation or depression or T-wave inversion. That might represent ischemia or poor blood flow to the heart, left ventricular hypertrophy, if there's Q waves already on the EKG, if in terms of heart block, if there's type 2 or higher atrial ventricular block, not type 1, but type 2 or higher, then you would potentially consider additional evaluation, bundle branch block, left bundle branch block or right bundle branch block, but particularly left. Of course, atrial fibrillation and QT prolongation. And that's a rough list right there, but that's the list of ones that I think you should be really worried about in terms of getting further evaluation. And so this is a nice sort of algorithm right here. So if they're undergoing an elevated risk surgery, so intermediate or high risk, so that's your like orthopedic surgeries, your vascular surgeries, and they have a known CAD history, arrhythmia history, stroke history, so on and so on. If that is the case, then you should obtain an ECG. If they don't have any of those risk factors, meaning if they really don't have a cardiovascular history, it's a class 2B indication to obtain an ECG. So nobody would fault you for saying that patient doesn't have any sort of cardiovascular history. So I'm not super concerned. Maybe I'm just going to ask functional capacity questions. Maybe I'm just going to ask them, if they have any sort of symptomatology at all, like chest pain or shortness of breath. And then if they're undergoing low risk surgery, and I'll give you this example. I had a lady that came in, no history, no cardiovascular history, undergoing breast augmentation, got an ECG, showed a first degree block, and she came to me. But she's undergoing a low risk surgery. She has no cardiovascular history. So it's actually a class 3 indication to get an ECG, meaning we really shouldn't do it. There's no benefit. And so you may say, well, what would ever hurt somebody by getting an ECG? Where it potentially hurts is in that particular case, if I had ordered further testing, so say I had ordered an echo or put her through a stress test or a CT scan, then I could have exposed her to different things like contrast dye, or maybe she would have an falsely positive stress test and then go for a cath. So I think one of the things I tell my trainees and my fellows is be really careful, because more testing seems like a good thing, but more testing begets more testing, which can potentially harm a patient. Now, what about biomarkers? This is one of my more favorite things to do. If I have a patient that is undergoing some sort of elevated risk non-cardiac surgery, intermediate or high risk, they're older, they maybe have a known cardiovascular history, I really like to get pro-BNP. I think it's a great way to further risk stratify a patient, not because necessarily the absolute score or the absolute BNP tells me a lot of information, but if it's normal, that gives me a lot of reassurance. If it's elevated, it may say, okay, well, maybe I consider in the right patient doing a resting echocardiogram. So I'm not opposed, and I think 2A indication for proBNP in patients that have known cardiovascular disease are older. Now, cardiac troponin, I think this is important to know, 2B indication, so weaker indication for cardiac troponin. And why is that the case? So particularly with high sensitivity cardiac troponin these days, we know that you can have chronic elevations in cardiac troponin if you're a diabetic. If you have stable diastolic heart failure or HFpEF, you can have chronic elevated troponin. So cardiac troponin may not be helpful, really should be ordered mostly in settings where the patient has actual symptoms, but there is a 2B indication here for it. So I'm going to stop there and just present a case here. And all of these are cases that I've had at some point. This was a 65-year-old male with history of coronary artery disease remotely, status post. This was stent procedure 8 years prior, awaiting evaluation to be cleared to undergo left knee replacement. So one thing I would just caution all of us, and I'm very careful to remind people that ask me to clear patients, I cannot clear a patient. I cannot absolutely say with 100% certainty that that patient won't have some sort of complication or perioperative cardiovascular event. I can help you risk stratify them. So from a medical legal perspective, I'm always very careful in my notes and in the forms I fill out to say risk stratified. This is a low-risk patient undergoing a low-risk procedure. That's my risk stratification. I think that's really important to change that lingo. This patient complains of dyspnea, so they're having shortness of breath, they have lower extremity edema that has been present for the past 2 months, but is not something that's been present, for years. The patient denies chest pain, syncope, palpitations. What does the patient need as additional evaluation for risk stratification? So this patient has prior cardiovascular history. They're undergoing an orthopedic surgery, which is in that intermediate column in terms of types of procedures, and they have symptoms, most importantly. So in this patient, I would be thinking about getting an ECG to see if there's any changes there, and I would be thinking about likely a resting echocardiogram with potentially a pro-BNP. I think the pro-BNP would help me know a little bit more about the heart failure, and the echo or the ultrasound of the heart would help me know a little bit more about their status in terms of their ejection fraction and their right ventricle. So this goes into when to assess function prior to non-cardiac surgery. So for new shortness of breath, new physical findings of heart failure, so that would be the lower extremity edema that I was talking about, crackles on exam, elevated JVP, or suspected new or worsening LV dysfunction. If you have any of those and you can answer yes, then you would say this is a known and the patient has a known diagnosis of heart failure, then you're definitely 2A indication thinking about preoperative assessment of LV function. If they don't have a known diagnosis of heart failure, but they have those new exam findings, then it's actually a class 1. So the strongest recommendation to get a preoperative assessment of LV function. So really important, symptoms with known diagnosis, yes or no, likely you should be thinking about an echocardiogram or some assessment of their function. Now, what if they have no symptoms? They come in and they say, feeling great. I don't have any exam findings of heart failure. I'm not short of breath. I'm able to walk up 2 flights of stairs. We should not be getting routine preoperative evaluation of the LV, predominantly because it could lead to downstream testing that's unnecessary and it's very costly to our system. Now, I think this one may be the most important, when to perform preoperative stress testing. So I think, a lot of our inclinations would be, well, let's just perform stress testing on everybody that's in this intermediate or high risk procedures, because that would make sure that nothing's potentially going to happen to them. So stress testing, keep in mind, about 20% of stress testing will be false positives or false negatives. So stress testing is imperfect. The gold standard is really a heart catheterization. So keep that in mind when you're getting stress tests, particularly in women. So I see this almost every week. A lot of my women patients, there's breast attenuation or breast artifacts present. If they have a left bundle, they maybe have a falsely abnormal stress test. So when you're thinking about it, when the patient has a low risk for preoperative cardiovascular events, they don't have a history of cardiovascular disease, they're undergoing a low-risk procedure. Remember, I showed you those low-risk procedure column earlier, and they have a functional capacity of 4 METs or greater with stable symptoms, then routine stress testing is not recommended. So if they have those components, if they're low risk coming to you, my lady that I was talking about in clinic that had the 1st-degree heart block, she's completely asymptomatic and she's getting breast augmentation. That lady should not have a routine stress test performed. Now, what about the flip side? What about patients? So oftentimes you'll have patients that come and you can't assess their functional status because they can't move around. Maybe they're coming because they need a knee replacement. So they're not walking a bunch upstairs because they have pain. So it's hard to assess that. Or they're undergoing an elevated risk non-cardiovascular procedure. So most common one I'm thinking about is the gentleman that's undergoing a knee replacement That's an orthopedic surgery. Can't do a lot of functional, can't do a lot of walking up and down the stairs because his knee hurts. And maybe he has a history of a TIA, or maybe he has a history of a prior stent. So in a patient like that, you would consider a stress test to evaluate for inducible myocardial ischemia. But keep in mind that it's still a class 2B recommendation. It's not a 1 or a 2A, it's still a 2B, even for a patient like that. And I think that the important thing to note is symptoms really trump all. If a person comes in, and I spend a lot of time really trying to tease this out and saying, well, I know you're not active. I know you're not doing much because your knee hurts, but when you walk to the mailbox, do you ever get angina? Do you get short of breath? What other kinds of symptoms are you having? Sometimes you can kind of parse it out, but if they really don't have great functional capacity and they have elevated risk, oftentimes you do have to do a stress test to further evaluate whether they have inducible ischemia. Now, cardiac CTAs are becoming so popular. I love ordering them because they give me such a very specific and accurate result. And oftentimes I take those patients to the heart catheterization lab, and I find that the CCTA findings are very similar to what I find in the heart catheterization. But still, there's a lot of risk to this, right? So CCTAs, I have plenty of patients that have advanced kidney disease. And so, it's still contrast dye that you're giving them in order to do these procedures. So if a patient has low risk, they're a low surgical risk, they're undergoing a low risk surgery, and they have adequate functional capacity, really should never be thinking about CCTA. So it's not recommended. There's no benefit. It's a 2B indication if they have a high patient risk, a high surgical risk, and you really can't assess their functional capacity, or it's poor. You can consider a 2B. So I will say personally for me, if I can't assess their functional capacity, or it's poor and they're at high risk, I oftentimes think about CCTAs, just because I know that the results will be quite accurate. There's not as much risk for attenuation. If they have normal kidney function, I can get it back pretty quickly, and I can get a good result that hopefully will keep them from having unnecessary heart catheterizations. All right, this is another case presentation here. So this was a 62-year-old patient presenting to clinic with end-stage liver disease. This patient was awaiting a liver transplant. He has severe osteoarthritis of his hips, so he can't ambulate or walk around his apartment, and has difficulties with stairs. Unfortunately, he has a pretty significant history. So he's had prior coronary artery disease with stents to his circumflex. He has atrial fibrillation on oral anticoagulations. Now, unfortunately, that's held because his platelets are so low. And he has a previous history of peripheral artery disease. So how would this patient be further evaluated prior to his transplant? So in this particular case, I couldn't assess his functional capacity because he really couldn't walk very much. He was hurting so much in his hips. He has end-stage liver disease, but he has really elevated risk in terms of cardiovascular disease. So he's undergoing liver transplant, which is a high-risk procedure. So it's a high-risk procedure. It's a high-risk patient, and I can't assess his functional capacity. So in that case, his kidneys were fortunately normal. I did a coronary CTA. I found that he had blockage, but they weren't actually flow limiting when I sent FFR. So one of the great things about CCTA is it not only shows you the percentage of blockage in each of the vessels, but then you can also send it for something called fractional flow reserve that is automatic, and it'll tell you actually if each of the blockages is significant or not, meaning does it need to be fixed with a stent or not. In this case, I didn't need to fix anything. It gave me a very fast result, and I was confident in the result, and he was able to keep going to his liver transplant evaluation. So here's the diagram for approaching the evaluation of patients undergoing non-cardiac surgery. So if it's an emergency surgery, if the patient's coming in, it's emergency surgery, life or death surgery, then you just proceed to surgery. Even if they have elevated cardiovascular risk, do the best you can to control their blood pressure and make sure, they have blood available and things like that. But ultimately, you've got to do whatever is going to save their life and deal with the consequences later on. If the patient, the next question you would ask is, if it's emergency surgery, go straight to emergency surgery. So what about if it's not emergency surgery, then what do you do? The next question you ask is the patient having an acute coronary syndrome? Meaning, are they having a heart attack? Do they have an unstable cardiac arrhythmia like ventricular tachycardia? And are they in a heart failure exacerbation? If any of those are present, you really, really, if you can, you want to stop and try to manage those. With an MI, you want to get them to the cath lab. If they're having ventricular tachycardia, you want to try to maybe get them out of that arrhythmia. Or if they have heart failure, try to give them Lasix and other diuretics to tune them up, so to speak. Now, if they don't have any of those really serious concerning findings, then you go on to a perioperative risk estimation. Then you're looking at that risk calculator I was talking about, like the RCRI, plus ask them things like, do you have valve disease? Has anybody told you have valve disease? Have you had prior stents? Do you have a defibrillator or pacemaker? Have you had a recent stroke? Has anybody ever told you had congenital heart disease or pulmonary hypertension? So those are kind of the major things you want to be looking at. Those are really big findings that would be important for both the cardiac, or rather not the cardiac anesthesiologist, but for the anesthesiologist to know, as well as the surgeon. And so this is a really complicated chart, but let me just simplify this down to say, if you're low risk, so on the left side, if you're low risk, and you don't have any of those risk modifiers, you don't have bad aortic stenosis, you don't have pulmonary hypertension, go on to surgery. If you have elevated risk, but you don't have all of those other findings like valve issues and pulmonary hypertension, recent stents, then you assess their functional capacity, you consider an ECG, and you continue to determine whether further testing will actually impact the decision making. If they have risk modifiers plus elevated cardiac risk, those are the patients where you're really thinking about, could an echo help me in addition to an ECG in further medical therapy? So really, I think this is a great way. I have this hung up in my office to sort of help my fellows and my trainees understand how to think about these patients. They're low risk with no risk modifiers, proceed to surgery. If they have those risk modifiers, you can think about other things like ECGs, biomarkers, and other testing like this. So I would encourage you, I think these slides will be available afterwards, to really pull this particular diagram out to try to figure out which patients need the echo, need the stress test, and need the biomarkers. So let's talk about perioperative management of acute coronary syndrome. So this is not, unfortunately, an uncommon thing at Duke. I feel like I deal with a couple of these every single week. So about 18% of patients undergoing non-cardiac surgery actually have coronary artery disease. And so, those patients, particularly if they're presenting with an acute coronary syndrome, you have to prioritize getting preoperative revascularization performed. So if they have a true ACS event, meaning they have some sort of plaque rupture in their coronary artery, they have troponin elevations, they have STEMI on an ECG, you have to go ahead and manage that. The other patient, so that's a class 1 right there, which always go to the cath lab. Now there's this 2A group that I think is pretty important as well. There are not many blockages in the coronary bed that I would say should really hold up having an important surgery for a patient, but there is one. And for me, that is significant left main disease. And even though the guidelines just say left main, I think most of us would also say proximal LAD. That's sort of an equivalent to left main. For the purpose of the guidelines, it says left main blockage of 50% or more. You really should consider some sort of preoperative revascularization, meaning either a stent procedure or maybe even bypass surgery, because the left main supplies so much of the heart. It supplies the LAD and it supplies the left circumflex system. And if there is some sort of plaque rupture or further blockage of that left main during a big procedure, during a big surgery, the patient could potentially have a bad outcome. Now, for patients with non-left main coronary artery disease, revascularization is not recommended. So again, shouldn't just be sending patients to have every little blockage fixed prior to a procedure. So for management of hypertension, again, many patients are going to have high blood pressure that are undergoing a non-cardiac procedure. And I think the really big recommendations to remember is intraoperatively class 1 indication to maintain the mean arterial pressure somewhere between 60 to 65, the systolic blood pressure above 90. So intraoperatively, that's a class 1 indication. Also a class 1 indication in the postoperative setting. You don't want patients to get too hypotensive or to have too low of a blood pressure. And then in the preoperative setting, it's a 2A indication to continue most of their medical therapy for hypertension throughout the preoperative period of time. So I think this all goes without saying. It's probably a part of your practice already, but just trying to make sure that they don't become too hypotensive or too low blood pressure. Now, what about managing the patient with congestive heart failure? Really, really big one here. Okay, for elective non-cardiac surgery, class 1 indication to hold the SGLT2 inhibitor 3 to 4 days prior to surgery. And you may say, why? Well, these particular drugs are great drugs for patients with heart failure, but can be associated with a metabolic acidosis that can occur during a surgical window of time. So you want to hold these drugs so that their half-life is significantly out of the patient's system by the time of their surgery. Now, for compensated heart failure undergoing non-cardiac surgery, also reasonable to continue other medical therapies, but excluding SGLT2 inhibitors. And for those, and I think this goes without saying, who have very decompensated heart failure or hemodynamically unstable heart failure, you want to try to postpone elective surgery. I think this is just a good reminder that there's a significant association between the left ventricular ejection fraction and 90-day mortality in patients undergoing non-cardiac surgery. So many of the patients that I see have an LVEF less than 30%. And you can see their crude mortality rate at 90 days is over 8% if they have a low EF or a low ejection fraction. If they have a normal ejection fraction, no heart failure, around 1%. So really the ejection fraction gives you a good amount of information about the patient's risk for dying during that preoperative window. Now, hypertrophic cardiomyopathy, I think you may see some of these patients. I think just important in these patients to know not what you should not do. So do not introduce factors that can aggravate or trigger dynamic outflow obstruction. So starting them on inotropic agents, diuresing them a lot, so reducing their preload, giving medications that can increase tachycardia. Those can be potentially harmful and cause hemodynamic instability. I think in general, if you have a hypertroph that's undergoing non-cardiac surgery, important to consider a cardiology consult for those patients. Now, not unusual to have a patient with aortic stenosis needing to undergo non-cardiac surgery. I had a gentleman that needed a hip replacement. He was in terrible pain. And I listened to his heart. He's been having some shortness of breath. So let's go through the algorithm. So he was having some shortness of breath. He had a history of a prior stroke. So I got an ECG. Because of his symptoms, I got an echo, and because I heard a murmur when I examined him, and I found that he actually had severe aortic stenosis. So in those particular patients, if it's an elective procedure, you really should try to consider getting the aortic valve fixed before you undergo non-cardiac surgery. They can be put under a lot of stress during the surgery with anesthesia that can be quite harmful to the patient. So class 1 indication, if they have severe AS, get it fixed beforehand. If they have suspected moderate or severe and they're undergoing elective risk non-cardiac surgery, try to get an echo. And this is just, again, a nice diagram here showing if they have symptomatic aortic stenosis and it's an elective, you should really be trying to get the valve fixed. If they have asymptomatic aortic stenosis and a elevated risk surgery, so it shows, let's just go through this algorithm. Asymptomatic aortic stenosis, they have a normal ejection fraction, they have an elevated risk surgery coming up. If you can delay it, really important to try to delay it to determine the safety profile of potentially undergoing. Same with mitral valve surgery in patients with severe mitral stenosis. They should be evaluated for the need for a mitral valve intervention prior to elective non-cardiac surgery. Now, if the patient has severe MS or severe AS, and they have an emergent procedure that needs to be done that's going to be life-threatening if it doesn't happen urgently or emergently, then you do your best to work with your cardiac anesthesiologist to try to get the patient through that procedure from a hemodynamic standpoint. But I do maintain that if the patient has those findings and they need an emergent surgery, probably best to have it done in a large center where there is cardiac anesthesia available. And then again, in chronic aortic and mitral regurgitation, again, a class 1 indication to, if you suspect it, get an echocardiogram. If you can hold off on surgery to see if you can potentially get valve intervention, that is always best. Atrial fibrillation, very important. I'm sure many of you have many atrial fibrillation patients. So atrial fibrillation and non-cardiac surgery. So in the post-discharge setting, class 1 indication if they have new onset atrial fibrillation to send them home on some oral anticoagulation if they have a high risk stratification, meaning if their CHA2DS2-VASc is elevated and they don't have other risk for bleeding, a class 1 to go ahead and send them out with that and get them close follow-up. In the perioperative setting, if you find new onset AFib or rapid AFib, you want to try to control it, identify triggers that could be causing it, 2A indication to try to control it, and initiation of post-operative anticoagulation therapy can be beneficial. Again, 2A indication. Probably can't start it in the preoperative, or you may be thinking about heparin preoperatively, but definitely want to think about it post-operatively. Diabetic management. This goes without saying in patients with or at risk for diabetes who are scheduled for elective non-cardiac surgery, should think about A1C testing if reasonable and hasn't been performed recently. And again, and they bring this up many times, and it's because unfortunately we have seen so many indications of patients coming back or coming in with metabolic acidosis that didn't have their SGLT2s discontinued. So that's a really big one, class 1 indication to stop it 3 to 4 days prior. Transient ischemic attacks. So you guys probably know that the highest risk time for a patient with a transient ischemic attack is in the 3 months subsequent for having another subsequent either TIA or having a stroke. So 2A indication, if it's possible to delay the patient for at least 3 months, you can really help to reduce potentially them having another stroke or a major adverse cardiovascular event. Pulmonary hypertension, again, there's people that specialize in taking care of these oftentimes very sick patients. In the class 1 indication, if they're on some sort of medical therapy for their pulmonary hypertension, to try to continue these agents to reduce the risk for development of perioperative MACE. Seen a couple of times people try to stop the vasodilators and other medications for pulmonary hypertension prior to surgery, and then the patient has terrible flash pulmonary edema or has terrible decompensation. So really important. If you're not sure about whether you can keep the medication on or not, really need to talk to their consulting physician who is prescribing them that medication. Device management, I feel like people always have a lot of angst about devices prior to a non-cardiac surgery. I think it's important, you need to know what type of device it is. So if you can look and see if there was an operative note somewhere in the electronic health record that tells you, is it a dual chamber? Is it an ICD? Is it just a pacemaker? Importantly, what was the indication for the device? Was it just that they had low ejection fraction, and so they were putting in sort of a prophylactic defibrillator in case they had problems down the road? Or is it because they have complete heart block and they're dependent on that pacemaker? Those are really important things to know. And so I always go into the health record. I try to look under ECG or other device section and try to look at operative notes to see what the manufacturer and model is, as well as the indication. Most of the time, if they're not pacemaker dependent, or if they're not, have this very severe history of VT or VF that they need shocks for, it's not as concerning to put a magnet over it. But again, really need to know what the indication was before you go putting a magnet on it. So class 1 indication, you need to identify the type of device, manufacturer, model. Class 1 indication, if they're pacemaker dependent, having surgeries above the umbilicus, you should have the pacemaker reprogrammed or place a magnet on the generator to provide an asynchronous mode. And I would say, for the vast majority of clinicians, really the main thing you need to do is to determine what type of device it is, manufacturer, model, and then really need to be seeking out, if you have cardiology at your hospital, to make sure that they are sort of helping you manage placing it in an asynchronous mode prior to surgery. I'm going to keep, for the purposes of time, I'm going to go forward a little bit because I want to get through dual antiplatelet therapy and then have some time for questions. A 74-year-old with a recent STEMI last month, status post a stent procedure to the LAD, low ejection fraction, has a new wound on his right foot with concerns for really advanced peripheral vascular disease. I did an angiogram. I showed that there's really severe disease of the right common femoral, superficial femoral, popliteal, and anterior tibial. They recommend fem-tibial bypass urgently. The patients had a recent STEMI though, so last month. And we know our guidelines tell us that they should be on dual antiplatelet therapy for 12 months after a heart attack. And really, the least amount of time I would say with the new sense that you can get away with really with stopping dual antiplatelet therapy, unless you're going into emergency surgery, is about 6 weeks. So in a case like this, this is a complex decision making. You can use an IV intravenous antiplatelet drug like Cangrelor to help you bridge to a big surgery like this so that they can stay on an antiplatelet medication. Or you can say, is there other options outside of surgery to treat this disease, like balloons and stents? So just really encourage, I've seen a lot of recent stopping of dual antiplatelet therapies because patient needed to go to some procedure. And unfortunately, I just today took care of a patient in our ICU that had a large heart attack, large myocardial infarction from stopping antiplatelet therapy too soon after a stent procedure. So there are consequences that I want you to be aware of. Class 1 recommendation in patients with coronary artery disease undergoing elective non-cardiac surgery, perioperative management of antiplatelet therapy and timing of surgery should be determined by a multidisciplinary team. Importantly, try to keep their low-dose aspirin on and try to at least keep their other antiplatelet medicines on for at least 30 days if they've had a bare metal stent, or 3 months if they've had a drug-eluting stent. Now, we don't even carry bare metal stents in our supply anymore at Duke because the outcomes after bare metal stents are not great compared to drug-eluting. I would say 6 weeks to 3 months is about the shortest you can do for antiplatelet therapy for drug-eluting stents, unless it's an emergency procedure. And I really stick by that because I think there's ways that you can bridge those patients with cangrelor and other short-acting medications to keep them safe. In patients with prior stent procedure in whom an oral anticoagulant monotherapy must be discontinued prior to non-cardiac surgery, aspirin should be substituted when feasible, so that until the oral anticoagulant like your rivaroxaban, like your apixaban, can safely be administered. Okay, and then this is a great chart, I think, for any platelet disruption after stent procedures for non-cardiovascular. Again, bare metal, 30 days. Balloon angioplasty, we rarely do that anymore, 14 days. Drug-eluting stents, notice in red, and I just want to point this out, in red under ACS, if a drug-eluting PCI is less than a month, do not perform a non-cardiac surgery that is associated with harm. I saw an example of that very thing today. Chronic coronary disease, if drug-eluting PCI is less than a month, do not perform non-cardiac disease. It is associated with harm. So try to wait 6 months for chronic coronary disease, PCI, 12 months after ACS. So I'm going to go ahead and skip forward just a little bit because I want to make sure that we have time for questions here at the end. We've gone through a lot of material. The big things I really wanted you to get from today is understanding the risk factors, understanding the prediction tools. I showed you the RCRI. I showed you some of the risk modifiers, like if they have valve disease, pulmonary hypertension, understanding low risk for perioperative events, what that means, what good functional capacity means, and what low risk procedures mean, and when you don't need stress testing. The guidelines highlight when patients may benefit from stress testing prior to non-cardiac syndromes. Again, think about symptoms, think about their risk history, and think about your ability to understand the risk of the procedure and their functional capacity. Always stop the SGLT2 inhibitors 3 to 4 days prior to planned surgery. For oral anticoagulant therapy, you don't typically need to bridge it. So all these patients that come into you on these oral anticoagulants, keep in mind that the individual risk of stroke, individual day risk of stroke is quite low. So in most of those patients, you don't need to bridge them, only in the very high-risk patients that have mechanical valves or have a very significant history of stroke. Early cessation of DAPT in the post-ACS patient or post-PCI patients should be carefully weighed against the urgency of the surgery and timing from PCI. And if you have a patient that's less than a month out from a drug-eluting stent PCI, please, please, please call cardiology. There's many things we can help you do in terms of intravenous drugs to help reduce the risk of those patients. So I'm going to go ahead and stop there. I didn't get through everything, but I think I got through the most important stuff. And so I want to have a few minutes for questions.
Questions for Dr. Reimer? Dr. Reimer, I was really pleased when you made the point about if you're doing a pre-op clearance, be it an outpatient or an inpatient, talking in terms of the relative risk rather than clearing them. I think we have a lot of residents on our call tonight, and we have a lot of outpatient providers who I know are asked that in their clinic setting for things that are non-urgent. And I just would echo what she has said, that when you say you've cleared someone, you've undertaken a lot of personal liability about that. So basically, dealing in terms of relative risk in your note and your advice to your patient is just a really smart way to approach that. Mary, are these
Dr.
questions?
Reimer, are you able to see the question that's in the chat box?
I am. So
Okay.
I see from Sally Ann McIntosh, thank you for your presentation. Thank you. A patient requiring lifelong anticoagulation and MI with PCI and 2 drug-eluting stents 4 weeks prior was admitted with an acute upper gastrointestinal bleed. EGD shows no active bleeding or peptic ulcer disease. Would you recommend discontinuation of aspirin on discharge at this juncture? Hospitals are often looking for direction from GI and cardiology with this scenario. Thank you. Great question. Really common to occur. I think this is a really critical time. That first 6 weeks. So let me step back and say, well, why is it so important? Why do I care about that first 6 weeks of antiplatelet therapy after stent procedure? It's because until the stent has basically invaded the wall of the artery, there is high risk of acute stent thrombosis behind the wall of behind the stent strut into the wall, and so that's what we see a lot. So in this particular time, a lot of times I think about Cangrelor because Cangrelor has a half-life of 4 minutes. So I try to put the patients on, and if they start bleeding again, can stop them quickly. But I would at the very least, try to continue the clopidogrel. If you're uncomfortable with the aspirin, or GI is oftentimes uncomfortable with aspirin, especially if there is peptic ulcer disease, at least you need to try to continue clopidogrel. And notice I didn't say ticagrelor or prasugrel. Once they've had a big bleed like this, I always just take them down to clopidogrel. It's a lower intensity P2Y12 inhibitor, but it at least gets them on a P2Y12 inhibitor that can help keep that stent safe. So I would say if you have to, consider getting rid of the aspirin, but please keep that clopidogrel on. And unfortunately, and I hate to say this, and I say it flippantly, having managed these patients, you can always transfuse the patient through the bleed when the heart is dead or akinetic from a STEMI. Really hard to treat those patients. So that's a great question, really hard one.
Other questions?
Yeah, and just to another point, I would say really important. So I have a dot phrase that I put in my cardiac clearance notes. It says Mr. X is low risk for a blank risk, and it can auto-populate based on what I've seen in there. I go to the nth degree of marking out. They have these, is the patient cleared or not? I exit out and I write stratification because I think it's just asking too much out of the provider to predict the future.
This is a very dense document if you looked at it, and Dr. has done a nice job of, if you will, giving you the highlights. I just want anyone on the call who has this as an activity in their practice, you truly need to review the document yourself, and you can easily find it. You can just Google American Heart Perioperative Guidelines. It'll pop right up, 2024. If you have any trouble doing that, if you'll just shoot me an email, or Mary or Van, we'll be more than happy to send you the link, because it's really the gold standard right now, probably.
And I think if you're trying to look for really quick, like high yield, the highest yield algorithm is on the stress testing and discontinuation of dual antiplatelet therapy. That's a really high yield. The stress testing one is great just to stick up on the wall in your clinic And it's great to sort of go through, was this patient this and this and this, and it helps you figure out whether you should stress them or not.
Any other questions or comments for Dr. Reimer? Mary, is there anything else in the chat we need to address?
No, that was it.
Okay, well, Dr. Reimer, any final closing comments? You've been superb with your
No.
time. Good job.
Thank you. These are really tough questions. I am always happy to get questions from people, especially around antiplatelet therapy. It's a big passion of mine, or oral anticoagulation. If you ever have questions, I think my email or something is maybe included here. But feel free to pass along. Always happy to think through situations or combinations with you, because I think it's unfortunately I see all too often the consequences of sometimes these perioperative situations that maybe we could work together to manage a little bit better.
Well, Dr. Reimer, thank you so much.
Right.
We very much appreciate everyone being on the call, and we hope you'll rejoin us again next week. Same time, same station, same time, and on Teams for UTI stewardship with Dr. Gettler from infectious disease. That being said, please be careful out there. Have a great evening. Bye-bye. Take care.
Thank you so much.